Hi, I'm Cynthia Matossian from Matossian Eye Associates. I was invited to do a short video on in-office MGD treatments and how to be efficient in the practice. Obviously, we're seeing patients. It's taking us longer to see patients because of all the COVID-related activities. So how can we integrate MGD treatments while still staying efficient? And that's a big key. It all starts with having a team that's defined as the dry eye team, and to have protocols and procedures in place. And at our practice, this is what we do. I'll share my secrets with you. The first thing is that my staff is educated. I spend time training my technicians, who are my screeners and my scribes. They are empowered to ask the following 3 questions to our patients. We no longer have our patients complete OSDI or speed questionnaires. It was taking too long. If, on the other hand, you had a platform where you could pre-visit, send them the questionnaire. MD Backline has a new module for dry eye, for example. That would work great. We're looking to integrate that into our practice, but we don't have it yet. Consequently, we ask the following 3 questions, and the screeners do this. How many times a day do you use artificial tears? Not do you use artificial tears, how many times a day? Clearly, if somebody says, I use tears occasionally versus I use them 20 times a week, that's a very big difference. That tells me a lot as the treating physician. The second question is, do your eyes feel tired? And the third question is, does your vision change throughout the day? We used to use the word fluctuate throughout the day, and then we realized that some of our patients did not understand what the word fluctuate meant, and they were embarrassed to ask, so they would say no. So, does your vision change? How many times a day do you use the tears, and do your eyes feel tired? They're also empowered, my staff is also empowered to do the following 3 tests on every one of my dry eye consults: tear osmolarity, MMP9 testing, and mybography. And actually, even with tear osmolarity, they write the outcome, for right eye, left eye on one of the cards, so I can hand the card to the patient. So when I come into the room, the 3 questions are there on one of my screens. On the second screen, I have the mybography image. So I immediately start with that. We go over their history. And this way, everything is there up between the 2 screens, and I can demonstrate their mybography, review the black and white piano key images with my patients, and go into the TO, tear osmolarity data, MMP9 data, and I actually hand the patients the test strips, the pregnancy looking like tests. They hold it, they look at it so they can see the red or the lack of the red. All of this, of course, is being documented by my scribe. Then accordingly, a customized treatment is designed for the patients. Of course, I do a slit lamp exam. I use lissamine green and fluorescein on every one of my patients. Let's say the decision was made to proceed with a LipiFlow treatment. We offer it either on the spot, meaning you're here, Mr. Smith or Mrs. Smith, let's do the procedure. They pay for it first. We learn the hard way. Then we do the procedure. Or we ask them to come back on a different day, depending on how the day is running, how busy the schedule is, and whether the patient has time or not. Other treatments like IPL are scheduled because they take a little longer. And the IPL in my state, where I practice, New Jersey and Pennsylvania, pretty much physicians have to do the IPL. It's very difficult to delegate an IPL to a non-MD, especially in Pennsylvania. So I have to do it from beginning to end. Consequently, the IPLs are always scheduled, so I don't run behind. Whereas LipiFlows, what I do is, after the patient says yes, the technician goes through the consent form, they go into the LipiFlow area, I come in when they're already in position and we recline the chair about 45 degrees. I come in, I put the anesthetic drops in the patient's eyes. We open the peel packs of the sterile activators and I place each one in each eye, tape it in position, and leave, letting the patient know that I'll be leaving, handing them off to a very seasoned, knowledgeable technician, and the technician stays in the room for the remaining 12 minutes with the patient. During that time, the patient is a captive audience, and my staff goes over the importance of adhering to all the at-home remedies that I prescribe, the importance of the sequencing of the different drops and procedures if they happen to be doing, let's say, lid scrubs, and putting in a medication in their eye, or using a heated microwavable mask, and when to best take their oral omega-3 supplements. All of this is described and reinforced to the patient during that 12-minute time. Other procedures we are now reintegrating post-COVID into our armamentarium. We're going to be training our staff to do tear care. We're going to be doing BlephX, and we're going to be doing iLux. And our plan is for a group of technicians to be trained and become expert at these. I am going to suggest it to the patient, either again on the fly, you're here, we can do it, or come back at a scheduled time. And those procedures are going to be done by the technician. However, I will come into the room either pre or post procedure to make sure all is set up right and it ends well and confirm that the process was completed appropriately. So it's a hybrid system of to offer the procedure to the patient on the spot. We know that more patients say yes doing it that way because sometimes when patients schedule out into the future, things happen in their lives or they cancel or other financial commitments come up where they say, well, I'd rather spend my money on a new X, Y, and Z that I need for my kid or for myself or my car than pay for an in-office treatment. So you, as the captain of the ship for the day, have to decide, can I add a procedure on the fly, or how many can I do it without impacting the clinical flow? Also, kind of streamlining what happens in the exam room by having all the data available to you so you're not spending time looking for the various diagnostic test data. All together as a team, it works beautifully, effortlessly, very efficiently, and it does not add all that much time to the average patient throughput. I hope this was helpful. If you have other questions for me, don't hesitate. Let me know via email, and I'd be happy to continue to answer your questions. Thank you very, very much.